Good morning, everyone. Today we are going to study about oral habits. Let's see what are oral habits in orthodontics. So, the topic oral habits in orthodontics covers a wide range of habits. Oral habits in children bring about harmful and unbalanced pressure to bear upon the immature, highly malleable alveolar ridges, the potential changes in position of teeth, and occlusions, which may become decidedly abnormal if these habits are continued for a long time. Let's see what are the definitions of habit. Darwin said that it is a fixed or constant practice established by frequent repetition. Maslow said a habit is formed reaction that is resistant to change, whether useful or harmful, depending on the degree to which it interferes with child's physical, emotional, and social functions. Habits are learned patterns of muscle contraction, which are complex in nature. William James classified habits into useful habits, which includes habits of normal function, and harmful habits, which includes all habits which exert pressures, stresses against teeth and dental arches, and also mouth breathing, lip biting, and lip sucking. Clean said that there are empty habits and meaningful habits. Empty habits are those habits that are not associated with any deep rooted psychological problems, and meaningful habits are those that have a psychological bearing. Morris and Bohanna said there are non pressure habits and pressure habits. Non pressure habits are habits which do not apply a direct force on the teeth or its supporting structures are termed non pressure habits, whereas pressure habits are sucking habits like lip sucking, thumb sucking, tongue thrusting, biting habits like nail biting, needle and thread holding, posturing habits like pillow and hand rest, and miscellaneous habits like bruxism, cheek biting. Finn said that there are compulsive habits and non-compulsive habits. Compulsive habits are deep-rooted habits that have acquired a function in the child to the extent that child rotates to the habit whenever his security is threatened by the events which occur around him. The child tends to suffer increased anxiety when attempts are made to correct the habit. Non-compulsive habits are easily learned and dropped as the child matures. So, based on the nature of the habits, Kingsley classified habits as functional oral habit, example mouth breathing, muscular habits like tongue thrusting, cheek or lip biting, combined muscular habits like thumb and finger sucking. Postural habits are chin propping, face leaning on hand, abnormal pillowing. Graeber in 1976 included all habits under extrinsic factors of general causes of malocclusion, like thumb or digit sucking, tongue thrusting, lip nail biting, bobby pin opening, mouth breathing, abnormal swallow, speech defects, postural defects, psychogenic habits like bruxism, defective occlusal habits. And let's see what is thumb sucking. Galen said that placement of the thumb or one or more fingers in varying depth in the mouth. Synonyms are thumb sucking, digit sucking, finger sucking. Thumb sucking can be classified into normal thumb sucking and abnormal thumb sucking. Abnormal thumb sucking is psychological or habitual. Normal thumb sucking could be seen 1 to 2 years, 3.5 to 4 years, no malocclusion. The other in preschool, there is malocclusion, the stance of malocclusion. What is sucking reflex? Starts at 29 weeks intrauterine, disappear by 3 to 4 years, is the first coordinated muscular activity, psychological and nutritive need. It's due to the psychological and nutritive. Rooting or placing reflex is well-defined sensory area around mouth, head turning and opening of mouth by stimulation, lasts for 7 months of age. Grading of classification, thumb sucking, is given by Subtilny in 1973. It's type A, type B, type C, and type D. Type A, 50% of the children, whole digit is placed inside the mouth with a pad of thumb pressing the palate. Maxillary and mandibular anterior contact is maintained. In type B, 24% of children, it could be seen, and thumb is placed into the oral cavity without touching the vault of the palate. Maxillary and mandibular anterior contact is maintained. In type C, seen in 18% of children, thumb is placed into the mouth just behind the first joint and contacts the hard palate and only maxillary incisors. In type D, seen in 6% of children, very little portion of thumb is placed in the mouth. So what are the causative factors? It's parent occupation, working mother, number of siblings, order of birth of the child, social adjustment and stress, feeding practices, and age of child. Factors affecting thumb sucking is the intensity, amount of force that is applied to the teeth while performing the habit, that is sucking, duration, amount of time spent sucking a digit, the frequency, number of times habit is practiced throughout the day, direction is the manner in which force is applied. So how will we diagnose this? Evaluate emotional status, history, there is questions regarding frequency, intensity, and duration, inquiry regarding feeding pattern, parental care of the child, presence of other habits. An extra oral examination, we could see the digits appear reddened, exceptionally clean, sharp, dishpan thumb clean with a short fingernail, callus formation on superior aspect, lips, the upper lips will be short and hypertonic, passive or incompetent, lower lip will be hyperactive. Facial form will be either straight or convex. And other features like presence of other habits, high incidence of middle ear infections, enlarged tonsil due to mouth breathing. These all could be seen. So effects in maxilla, that's the proclination of maxillary incisors, increased maxillary arch length, decreased palatal arch width, increased trauma to the maxillary central incisor. And effects on mandible, retroclined mandibular anteriors. Effects on interarch relationship, we could see increased overjet, decreased overbite, cross bite, cluster malocclusion, and anterior open bite. Effect on tongue, it causes tongue thrust, and in gingiva is hyperplastic. On radiologic evaluation, we could see SNA is increased. Other effects are this to psychological health, increased deformation of digits, more prone to trauma, speech defect, especially lisping. And how will we manage this? So the treatment consideration are psychological approach, Dunlop's hypothesis. It's a conscious or purposeful repetitions, reminder therapy, non-appliance, bandaging thumb cap, socks covering finger or hand. Chemical approach like pepper dissolved in a volatile medium, quinine, asafoetida, fremite. So these should be used in patients as a positive active and wants treatment to break the habit. Appliance therapy could be done if reminder therapy, reward therapy failed. Appliance therapy can be implemented with the child's awareness and cooperation only. So it should not be used as a punishment device. Habit discouraging appliances usually have positive effects within 2 to 3 months, but they should be left in place for at least 6 months to make sure the habit is completely controlled. Depending on the patient's cooperation, the kind of habit and the type of deformity, several kinds of removable, fixed or semi-removable appliances could be used. So removable habit breakers is simple Holly appliance with a piece of wire which could be embedded in acrylic resin. The main advantage is allowing the patient to remove it for eating and maintaining hygiene, good oral hygiene, but the disadvantage is that patient compliance is a major factor. We could also use fixed habit breakers. So it's an intraoral appliance attached to the maxillary teeth by means of 2 bands. The examples for habit breakers are bluegrass appliance. So it's a 6-sided roller. It could be slipped over a 0.045-inch stainless steel wire, which is soldered. We could use cord helix. So these are all about habits. Thank you, everyone.